Welcome to the class. Today is our 15th live session for MRCOG candidates, and today's topic is syphilis in pregnancy. This topic is very important for part 1 MRCOG as well as part 2 MRCOG point of view. Various SBA single based answer question as well as extended matching questions can be asked from this particular topic. Especially for part 1 candidates, microbiological aspect and pharmacological aspect of this particular topic is very important. For part 2, both SBAs and EMQs can be asked, so listen to this particular topic very carefully, and whatever I have highlighted in yellow color, they are those are either important concepts for understanding, or these are the recalls or can be asked in the examinations. So for today's talk, we are going to discuss two articles. One is a syphilis in pregnancy, and second is the UK National Guidelines on the Management of the Syphilis, published in 2015. The first TOG is published in 2020, and this guidelines, UK National Guidelines, they are published in 2015. So these are the two articles from where I have taken all the slides. Okay, so syphilis is relatively uncommon in the United Kingdom, but recently there were many cases were noticed, and the syphilis co-infection along with HIV known is not uncommon. And according to the UK data, almost 40% of HIV patients can have syphilis co-infection. Syphilis is the leading infective cause of stillbirth in countries where it is endemic, and mother to fetal transmission is known, and it can lead to the low birth weight, stillbirth, congenital syphilis, etc. We are screening the patients for diagnosis of syphilis, and not all patients who are screened positive will require treatment. Only 40% of women who are screened positive will require antibiotic treatment. We'll see why all the screen positive patients will not require the treatment in subsequent slides. So what are the risk factors which are associated with this particular infection? The risk factors for syphilis in pregnancy will include low socioeconomic status, multiparity, history of sexually transmitted infections, use of illicit drugs before the age of 18 years, illicit drug use by the current partners, poor engagement with antenatal care, 3 or more sexual partners in previous 12 months. So if you have such a history in this particular your scenario is mentioning this particular high risk factor, just think of syphilis is one of the differential diagnosis. Okay. So how this particular disease is transmitted? The modes of transmission. It is mostly by the sexual contact. 1/3 of individuals exposed to the disease will become infected. Bacteria can also enter extragenitally. For example, like anal, rectal or oral route. Transmission can also occur transplacentally during any stage of the pregnancy, and the risk of transmission will depend on the stage of the maternal infection and the duration of fetal exposure. The early stage of the disease will describe the symptoms of primary and secondary syphilis. This is often followed by the period of quiescence. This is termed as latent syphilis. Okay, so during which there are no clinical signs or symptoms, but the patient remains infectious and serological blood test will be positive. So you have primary stage of syphilis, you have secondary stage of syphilis, and after this particular secondary stage, the disease will come quiescence, and it will go into the latent phase, or also called as a latent disease. Okay, and during which the patient is infectious, serological test will be positive, but there will be no clinical signs and symptoms. And over a period of times, maybe 15 years or 20 years down the line, it will land up into the tertiary stage or the late disease. Okay, so you have early stage, you have latent stage, and you have late stage. So early stage will include primary and the secondary syphilis. This is followed by the latent phase, latent disease, and then there is a late stage which includes the late stage of the disease. Okay, or the tertiary stage of the disease. Now we have just seen primary and secondary is followed by the latent disease. This can also be divided into two stages: early latent and the late latent. Okay, it is labeled as early latent when the infection has happened within the past 1 year. It is called as early latent disease. If the infection is more than 1 year ago, then it is labeled as a late latent. There is a little discrepancy between the two articles which I have already mentioned regarding the time frame which is given for the latent disease. Let's see about this discrepancy. Now look at the first article which is taken from the talk article. Okay, now here the second highlighted green highlighted area mentions early latent syphilis describes the infection that occurred within the past year, whereas the late latent syphilis describes the infection which occurred more than a year ago. This is what I have mentioned in the previous slide. Now, the second article, that is the UK guidelines on the syphilis, published in 2015, in the third line, in the second square, you just see this is about the latent disease, and what it says, this is defined as a late within 2 years and late thereafter. Okay, ending with the development of the tertiary disease. So this is defined as early within 2 years and late thereafter. So here the time frame which is given for the latent disease or early latent is 2 years, and the late latent is a more than 2 years ago. So this is what is the difference, and this I am just telling you because sometimes you remember only one figure and you find that that particular option is not there in the your various options which are given in the question. So remember, this both can be correct. Okay, so coming to the latent disease, so secondary syphilis will resolve spontaneously in 3 to 12 weeks, and the disease enters into the asymptomatic latent stage. This is defined as early within 2 years and late thereafter as per the UK 2015 guideline. The distinction between the early and latent disease is somewhat arbitrary, but why it is important? Because even if the patient goes into the latent disease or the latent syphilis, 25% will develop a recurrence of the secondary disease during the early latent phase. Okay, so when the patient is in the early latent stage, there is a 25% patient will develop recurrence of the secondary syphilis. Typically around 20 years later, patient may present with the stigmata of the tertiary or the late syphilis. This is termed as a late stage disease and is unlikely to be seen in obstetric population. Its complications are described as a neurological, dermatous and cardiovascular. So what we have seen up till now, this disease can be early stage, then you have a latent stage, and then you have a late stage. So early stage will include primary and the secondary syphilis. So after primary and secondary, it will become a latent disease. This can be early latent or the late latent, and the duration is either 1 year or 2 year for the early latent, and more than that will be the late latent, and this will be followed by the late disease, which will present with various complications which may be neurological, dermatous or cardiovascular. So late disease, the presentation is of three types. One is neurological, second is dermatous, and third is a cardiovascular. So this is all we are going to see various stages and its subtypes. Okay, so in this slide, on the left hand side, there is a figure which shows the primary syphilitic chancre. So you can notice a single lesion which is present on the vulva. It is this particular lesion is called as chancre. So primary syphilis, approximately 3 weeks following the exposure to the infection, and the incubation period is around 9 to 90 days. Okay, there will be single papule at the site at which the bacteria entered the body. It becomes a chancre. It is a painless, indurated and non-purulent lesion. Okay, so on the genital side, generally it is a single, that is solitary, painless and indurated lesion. But it can also occur at the extragenital sites. At that time, it may be this chancre, syphilitic chancre, can be multiple and painful. Okay, generally on the genital sites, you will have a solitary lesion which is painless and indurated. So chancres typically heal spontaneously over a period of 3 to 8 weeks. Approximately 25% patients will go on to develop secondary syphilis if they do not receive the treatment. Okay, now coming to the secondary syphilis. Again, here in this particular figure on the left side, you see a typical mucocutaneous rash of secondary syphilis. Okay, it is involving the palm of the hand. So systemic manifestations generally happen 4 to 10 weeks after the primary chancre, and the symptoms may be non-specific, that is general malaise, flu-like symptoms such as loss of appetite, lymphadenopathy, etc. But two things in the secondary syphilis we should remember, that is, one is a mucocutaneous rash which involves the palms and soles. Okay, and second is the development of the perianal condyloma lata. Okay, so one is a generalized mucocutaneous rash It may involve mucous membranes and can also occur on the palms and soles. And second is a perianal condylomata. These are nothing but the discolored, warty, highly infectious lesion, and they can also be extragenital. Okay. Other signs such as meningitis, eye disease like uveitis, optic neuropathy, hepatitis, glomerulonephritis, splenomegaly will also be there. So in secondary syphilis, so primary was a chancre that we have seen. Generally, it is a single solitary penless lesion on the genital side. It may be extragenital, and at that time it may be painful also and multiple also. In secondary syphilis, flu-like symptoms, non-specific weight loss, generalized malaise, etc. And two important things, that is mucocutaneous rash, and second is a perianal condylomata. Okay. Now let's go ahead. So secondary syphilis will resolve over a period of 1 to 3 months before entering to a dormant or latent phase. However, up to 1/4 of patients will develop a recurrence of the secondary disease in the initial part of latent period. We have already seen that 25% of the patients, once they land up in the early latent syphilis or the early latent phase, in the initial part, there will be recurrence of the secondary syphilis in 25% of patients. Now, late disease, which occurs approximately in 1/3 or 30% of untreated patients around 20 to 40 years after the initial infection. It is divided into three subtypes. That is, it can be a gametous disease, which is seen in 15% of patients, cardiovascular manifestation seen in around 10% of patients, and late neurological complication that is seen in around 7% of patients. The clinical manifestations of late syphilis are highly variable and are rarely seen due to the use of trypanosomal antibiotics for the other indications. Now, uh, in late disease, we have just seen that there are different presentation like gametous, cardiovascular, and neurosyphilis. Then gametous, that is in 15% of patients, cardiovascular in around 10% of patients, and neurological in 7% of patients. So we'll go into these subtypes. Gametous disease, that is seen around 15% of the developed will gametous disease. These are nothing but the granulomatous lesion with central necrosis. So it's a chronic inflammation with granulomatous lesion, and there will be central necrosis. Generally occurs within 2 years of latency, but are typically seen around 15 years after the infection. They can occur anywhere, but most common sites are skin and bones. They will resolve rapidly after the administration of therapy. So in gametous disease, we should remember around 15% of patients it is seen. Then skin and bones, these are the common sites, and it is because of the chronic inflammation, granulomatous inflammation with central necrosis. Okay, the presentation is around 15 years but can also happen early. Now coming to the cardiovascular manifestation, which is seen in around 10% of patients, and the presentation is around 15 to 30 years after the infection. It only becomes symptomatic or complicated in around 10% of patients. The site affected, this is very important because it is asked in the SBA, and once it was asked as a EMQ also. The ascending aorta is the predominant site of the damage, resulting in dilatations and the aortic regurgitation. So site of affection is the ascending aorta. So once there was an EMQ in which the site of affection was asked, and the various options such as abdominal aorta, ascending aorta, arch of the aorta, descending aorta, coronary ostia, various options were given. The common site of affection will be the ascending part of the aorta. Okay, rarely the coronary ostia may become involved and saccular aneurysms may develop. Now the third is the neurological disease, which is seen in 7% of patients. Okay, so in late disease, there are three types of presentations: gametous, cardiovascular, and neurological. So coming to the neurological, now these neurological manifestations can be of further three subtypes, in which one is a meningovascular syphilis. Typically, it happens around 5 to 10 years of infection. It can happen earlier also. Not typically considered to be tertiary disease. Infectious arteritis, which may result in ischemic stroke, and commonest territory of the artery which gets affected is the middle cerebral artery territory is getting affected. So it may present as ischemic stroke. The area affected belongs to the territory of middle cerebral artery, and prodrome may occur in weeks or months prior to the stroke, including headache, emotional lability, insomnia, etc. So that is the first manifestation, meningovascular syphilis, and the presentation around 5 to 10 years, but may present early also. Second is a general paresis. A general paresis of Insinn, it is also called as, the pathology here is the cortical neuronal loss. That is the pathology. Generally, progressive dementiating illness 10 to 25 years after the infection, secondary to the cortical neuronal loss. The two important things here we should remember about general paresis is the memory loss and personality change, leading to the dementia-like picture. Okay, so there is a forgetfulness, initial forgetfulness or memory loss, and there are personality changes which develop into severe dementia. Seizures and hemiparesis may occur. The timing of presentation is around 10 to 25 years after the infection. Okay, the pathology is a cortical neuronal loss in general paresis. Now, the last presentation in neurological manifestation is Tabes dorsalis. Generally, it happens around 15 to 25 years after the infection. That is the longest of the neurological complication, and it is characterized by the sensory ataxia, lightning pains. Pupillary abnormalities are common. A typical Urgil-Robertson pupil, that is called as Urgil-Robertson pupil, where a conversion reflex is present but the light reflex is absent. So you have a Urgil-Robertson pupil, and the joint position and vibration sense is lost, reflexes are absent. This is because of the affection of the dorsal column of the spinal cord. Okay, so that is the longest of the complication in neurosyphilis, around 15 to 25 years after the infection. That is Tabes dorsalis, affection of the dorsal column or the posterior column, leading to the loss of reflexes, joint position, vibration sense gets affected. You have typical Urgil-Robertson pupil. Okay, and there is a sensory ataxia, etc. Okay, the same thing what we have seen is the late disease. Here it is described. Late diseases of three types: gummatous, cardiovascular, and neurological. Okay, so gummatous is the earliest one. Presentation is around 15 years, can happen before that also, and it is a chronic inflammation. Sites are bones and joints, that is seen in the last line. Okay, then cardiovascular, around 10% of patients, 10 to 30 years. The ascending aorta is the commonest site. It may develop aortic regurgitation, etc. Then in neurological, we have seen meningovascular, general paresis of Insinn, and Tabes dorsalis. Okay, in general paresis of Insinn, what we have seen is two things: memory loss and personality change, leading to dementia-like picture. Then in Tabes dorsalis, dorsal column gets affected, and joint position, vibration sense, and absent reflexes, absent Urgil-Robertson pupil. So these were the manifestations. Okay, in the middle column, the timing of presentation is timing after the infection and the presentation of these manifestations, it is mentioned. So please go through this. Sometimes they may ask you on this particular as a SBA also. Okay, so this is what is the CSF picture in neurosyphilis. Various parameters such as what happens to the WBC count, protein, or VDR or RPR titer in both immunocompetent patient and in immunocompromised patients in neurosyphilis. So in neurosyphilis, in immunocompetent, that is HIV negative individuals, the WBC count in neurosyphilis will be more than 5 per microliter, and in HIV positive patient, it is generally more than 20 per microliter. Okay, and if the patient is on ART, in that particular case, it will be between 6 to 20 WBCs per microliter. Okay, while the protein will be more than 0.45 gram per liter in both cases. VDRL or RPR will be positive, and TPPA, that is Trypanosoma pallidum particle agglutination test, will be positive in the range or in the titer of 1:320. So this is what is the CSF picture in the neurosyphilis. Now coming to the another part. Okay, congenital syphilis. It is a separately we are discussing congenital syphilis apart from the spectrum of the disease which we have seen: primary stage, secondary stage, latent stage, and the tertiary stage or the late stage. This congenital syphilis is affection of the neonate or the intrauterine affection. The presence of signs at the time of delivery is dependent on the duration of maternal infection and the timing of treatment. And almost 2/3 of the neonates or 2/3 of the infants with congenital syphilis will be asymptomatic at the time of birth, and most will develop signs by around 5 weeks. Generally, by 5 weeks they will develop the sign, and the range is around 3 to 8 weeks, and most will present before 12 weeks after the birth. Okay, so that is further divided into two: early if it is diagnosed within first 2 years of life, or late when the presentation is after 2 years. It is called as late congenital syphilis. So congenital syphilis is also of two types depending upon the presentation of the timing. That is, within 2 years it is called as early congenital syphilis, after 2 years it is called as late congenital syphilis. Okay, so early congenital syphilis, which is diagnosed in the first 2 years of life, the common manifestations will include, and 40 to 60% will have at least one manifestation. There will be rash, hemorrhagic rhinitis, that is bloody snuffles, generalized lymphadenopathy, hepatosplenomegaly, skeletal abnormalities, and other signs will include condylomata, vestibulous lesions, osteochondritis, periostitis, pseudoparalysis, mucous patches will be there, perioral fissures, non-immune hydrops, glomerulonephritis, neurological ocular involvement, and thrombocytopenia, etc. So out of which we should specifically remember, one is a rash, second is a rhinitis, that is bloody snuffles. Okay, there will be hepatosplenomegaly and affection of the bone, that is osteochondritis and periostitis. Okay, so these are the common features. So sometimes they ask the question on the, they will give the various features in the neonate. They will ask you what is the congenital infection. Okay, so various options will be there, like CMV, toxo, etc., etc. So you need to remember infection and its specific pathology. So in congenital they can give you the timing of presentation also. So there may be early congenital, late congenital syphilis, etc., etc. Okay, so please remember these particular features, and you should not miss the rash, hemorrhagic rhinitis, and osteochondritis, periostitis, as well as hepatosplenomegaly, lymphadenopathy, etc. Okay, now coming to the late congenital syphilis. Late congenital syphilis presentation is 2 years after the birth. Signs develop as a result of chronic and persistent inflammation resembling gummatous disease in the adults. Stigmata of the congenital syphilis will include Hutchinson's triad. Okay, and what is Hutchinson's triad? It is eighth nerve deafness, interstitial keratitis, and Hutchinson's teeth. That is a notched incisors. Okay, so you have eighth nerve deafness, interstitial keratitis, and Hutchinson's teeth, also called they are the notched incisors. Then there will be Clayton's joints, mulberry molars, that is the maldevelopment of the cusp of the first molar, high arch palate, raggeds or the perioral fissures, frontal bossing, short maxilla, protuberance of the mandible, syphilitic rhinitis that leads to the saddle shaped nose, and anterior bowing of the mid tibia creates a classic Schaber shins. Okay, sternoclavicular clavicular thickening, paroxysmal cold hemoglobinuria, and neurological involvement. There will be intellectual disability and cranial nerve palsies. Okay, so we should remember Hutchinson's triad, that is eighth nerve deafness. Then there is interstitial keratitis and notch incisors. Okay, and apart from that there will be facial features such as frontal bossing, short maxilla, protuberance of the mandible, syphilitic rhinitis leading to saddle nose, and there will be Schaber shins. So these are the typical features of late congenital syphilis. The impact of the late congenital disease can be devastating, with 1/3 to 1/4 of the children presenting or after 2 years having asymptomatic neurosyphilis also. So the presentation may be asymptomatic neurosyphilis in late congenital syphilis. Okay, that is seen in around 1/3 to 1/4, that is 25 to 30% of patients may present as asymptomatic neurosyphilis also. Babies born with congenital syphilis are around 10% more likely to die in the first year of life. So neonatal mortality is quite high, in the range of 10%. But that can be prevented if the appropriate treatment is instituted. Now, diagnosis of congenital syphilis. We can diagnose it by direct demonstration of trypanosoma pallidum, by dark ground microscopy, and or polymerase chain reaction of exudates from suspicious lesions or body fluids such as nasal discharge. Okay, there are serological tests for the diagnosis. Serological tests should be performed on the infant's blood, not on the cord blood. And if the infant serum is positive on screening, we have to perform trypanomal IgM EIA. Okay, so we will be performing trypanomal IgM EIA, that is enzyme immunoassay. Then we have to also do the quantitative VDRL and RPR and quantitative TPPA on the infants and mother's blood in parallel. Okay, so we can do RPR or VDRL and quantitative TPPA test on the infant's blood as well as mother's blood. Okay, serological test detecting the IgG may be positive due to the passive transfer of the maternal antibodies whether or not the infant is infected. That is why trypanosome IgM EIA is very important. Okay. So the following, if confirmed on testing, a second specimen from the infant indicates the diagnosis of congenital syphilis. A positive IgM-EIA test, a positive RPR or VDRL test on CSF, a fourfold or greater difference of RPR or VDRL titer or TPPA titer above that of the mother, because we are doing we are processing mother sample as well as baby sample parallel. So if there is a fourfold greater difference between RPR, VDRL or TPPA titer between the mother and the baby's titer being higher. Okay, or if we are repeating the VDRL or RPR on the neonate sample over a period of 3 months and the titer is increasing, that is also suggestive of congenital syphilis. Or in a child more than 18 months of age, positive trypanosome test will indicate congenital syphilis. So how we will diagnose serologically? Presence of IgM EIA test, positive VDRL RPR on the CSF, and VDRL RPR or TPPA difference between the mother and the fetus, the fetal or the neonatal sample showing higher titers than the mother, or if we repeat the sample on the neonate over a period of 3 months and the titer is increasing, or if the child is more than 18 months of age, positive trypanosome test will indicate the congenital syphilis. Okay, now these are the Kaufman's criteria for the diagnosis of syphilis. So there are certain criteria, like they are divided into clinical and the lab criteria. Clinical are divided into absolute, they are major and minor, and absolute you have diagnosis by the diagnosis of trypanosome pallidum by dark cloud or PCR or histopathology. So if you have that is the absolute criteria for the diagnosis of syphilis. Then clinical major criteria are: one is a condyloma lata, second is a osteochondritis, third is a periostitis, and fourth is a snuffles, that is hemorrhagic rhinitis. You can remember bones. Okay, in bones you have osteochondritis and periostitis. Okay, then in skin you have condyloma lata, and nose you have hemorrhagic rhinitis. Bones, BONES, N for nose and S for skin, that is condyloma lata, and in bones you have osteochondritis and periostitis. That is how you can remember the major criteria. In minor you have perioral fissures, that is fissures of lips, skin rash, mucous patches, hepatosmegaly, splenomegaly, then generalized lymphadenopathy, neurological signs, hemolytic anemia, etc. And in serology there are 5 different types of picture you can see. So they are labeled as A, B, C, D and E. Okay, A, where you have positive VDRL and RPR, or TPP or TPHA is positive. B is positive IgM. C is negative VDRL or RPR, or TPPA or TPHA is negative. Fourth, D is a positive VDRL RPR which is not becoming negative within 4 months, and E is rising RPR or VDRL over a period of 3 months. So you have one direct demonstration of trypanosome pallidum, that is absolute criteria. Then clinical you have major and minor. In clinical, major remember bones, okay, osteochondritis, periostitis, condyloma lata, and snuffles, that is affection of the nose. Okay, and serology there are A, B, C, D, E. Now how to utilize and diagnose the congenital syphilis? Then diagnosis will be definitive diagnosis of congenital syphilis, or probable diagnosis of congenital syphilis, or possible diagnosis of congenital syphilis, or it is unlikely to be congenital syphilis. Then how? Let's see. Definite diagnosis if one or more absolute criteria, that is if you can demonstrate directly the trypanosome pallidum or the discharge or something like that by draw ground or PCR or histopathology, that is definite diagnosis of congenital syphilis. Then what is probable? In probable, when there is a serology E or D. Now what is E or D serology? That is when
RPR or VDR titer is either increasing or it is not becoming negative. Okay, so that is serology E or D. Or you can have one major criteria plus serology A or B. Okay, screening test, that is RPR, VDRL, TPPA and TPHA. These are the screening tests we will see in subsequent slides. When you have these tests positive with one major criteria, then we will label this as a probable. Or you have the same serological test, that is screening test, RPR, VDRL or TPPA or TPHA along with two minor criteria. Okay, so you can have one major along with serology A or B, or you can have two minor and serology A or B, that is a probable diagnosis of congenital syphilis. And last is a one major and one minor criteria can also be labeled as a probable diagnosis of congenital syphilis. Then what is possible diagnosis of congenital syphilis? Where you have serology A or B with no clinical criteria. You only have screening tests which are positive. However, clinically there are no major or minor features. That is the possible diagnosis of congenital syphilis. And it is unlikely if you have serology C, that is VDRL is negative, RPR is negative, TPPA, TPHA is negative, and there are no clinical criteria also in that particular case. There may be some maternal history, but there is no major criteria, there is no minor criteria, and the titers are negative. In that particular case, it is unlikely to be congenital syphilis. It is also unlikely when you have serology A or B plus mother is known to be adequately treated. Okay, so there is a complete adequate history of the maternal treatment and the serology is A or B. In that particular case, it is unlikely to be congenital syphilis. I hope you have understood this. Okay.
So look at these two pictures. Okay, on the left hand side you have an image which shows free fluid in the multiple compartments. The image will show the ascites below the diaphragm. So wherever A is mentioned, you can see the ascites. Okay, and the arrow with B shows the pleural effusion. So inside is a lung tissue you can see, and which is surrounded by the pleural effusion, that is on the left image. Okay, now come to this right image. It is a cross section through the fetal abdomen, and you can see the white lesion, that is nothing but the intrahepatic calcification, that is the hyperechoic areas with posterior shadowing. Okay,